Hey everybody, my name is Dr. Kanuga. I am a board certified pediatric dentist in private practice in the suburban Los Angeles area. And today I will be talking about how pediatric restorations can be fast, easy, and simple. The term minimally invasive can have different connotations. As a pediatric dentist, I'd love to be truly non-invasive and focus solely on the prevention of dental disease. However, in reality, the surgical management of dental disease is still an important component of our practice. And with the R&D and advances in technology, techniques, and dental materials, we can provide evidence-based, minimally invasive restorative care to our patients who still need it. So along those lines, today I'd like to share some clinical pearls on doing direct restorations, as well as some dental materials which can be a vital part of our toolbox in our patients and show you how easy, efficient, and productive it can all be. Here's a little sneak peek into how it all flows. I'm sure it resembles some of your practices in many ways. This office was designed by me with the theme around the world. Okay, so these, in my experience, are the key components of a successful and smooth clinical day. The key components being the right patients, the right team, the right schedule, the right setups, the right dental software, four-handed dentistry, optimal isolation, and last but not the least, dental materials. And let's examine how these play a role. The right patients, well, like I said, as long as they make the cut for pedo and they're healthy enough to be seen in a dental office setting, they are good to go. But again, this can be different for every practice. And the right team, I'm sure you can all unequivocally agree on how important having that right team is. And the right schedule, is a little glimpse into a typical busy day at the office. Our clinical hours being from 9 a.m. to about 4 p.m. with a 30-minute lunch break. So total clinic time being about 6.5 hours. So as a pediatric dentist on roller skates, so we're rolling from one operatory to the other, one child to the next, one helicopter mom to another granola mom with all the shades in between. I mean, you all know how important the right setup is and how it can affect the flow if we have things missing from the setup. The right dental software, a program that is easy enough to work with for the front and the back office and can integrate some external softwares as needed, is important. And four-handed dentistry is extremely important in pediatric dental practice or in a practice that sees kids, especially with the fidgety little kids. That's like the core of the dance. It's effortless and unprompted, and it can end up turning into 6 or 8-handed dentistry at times. Optimal isolation, again, cannot be underrated. Here this child is getting his restorations under isolation with nitrous oxide oxygen, and you can see how it just keeps everything nice and dry, keeps the tongue and the cheek and the soft tissues out of the way, comfortable for the child. You don't have to worry about being bitten or the mouth, not opening adequately or closing in between. So super, super important. And the best part is you can work on, multiple quadrants at the same time, upper and lower. And again, this is in the hierarchy of preference from a workflow optimization standpoint. The optimal isolation would be, for me, would be Isolite, Isovac, or Dry Shield, rubber dam isolation with mouth prop and bite block, and dry angle cotton rolls with a combination of mouth prop and bite block.
So we finished tooth number
Here's a rubber dam isolation.
OBL composite, and we're trying an upper right D6 SSC on tooth number B, first primary molar, after we remove all the caries. And pusher, please.
And pusher. It's
So that was an example of rubber dam isolation. So as you can see, by isolating the quadrant in a child, it allows simultaneous treatment of multiple teeth and gives us a clean working field. And you're not struggling to keep the soft tissues out of the way. Cheek pad. I'm going to put this cheek pad right here. I'm going to blow some wind now. Here, a little bit of wind like that. One wind right here, and a little wind on the bottom. And this is my floss, okay? Magic, look what I'm going to do. I'm going to make part of the floss blue. How cool is that, right? And then we're going to floss with this blue floss on the top. You have varnish handy, right? 1, 2, 3, 4, and 5. Perfect. And we'll do the same thing on the bottom. We'll just use a new floss, okay? Same thing. I'm going to blow some more wind there. I know this. Okay, so this was an example of isolation with bite block and triangle. As you can see, there is also a place for these in the pediatric practice, probably not so much for restorations, but for a procedure like silver diamine fluoride application for caries arrest, you know, that's definitely the least we can do. So let's look at dental materials and why the appropriate selection of those is very important. As clinicians, we have several choices in the dental marketplace. It can get overwhelming to make decisions from a gazillion options, all of which claim to be the best in their category. What sets us apart as doctors is that we base our choices of restorative materials on scientific evidence rather than anecdote, and we balance it with practicality and ease of use. So that's where the personal preference comes in. Also, a one-size-fits-all approach does not work out very well, and the materials are usually selected based on the particular case at hand. In pediatric dentistry, it is truly multifactorial, and a lot of the times a child's ability to cooperate can play a very important role in the selection of the materials. So here's a cross-sectional study from the recent Pediatric Dental Dentistry Journal, Early Childhood Caries in the US, National Health and Nutritional Exam Survey data from 2013 to 2018. So there were 3 consecutive cycles where the data was collected from 13 to 14, 15 to 16, 17 to 18. Kids were, majority of the children were under 6 years of age, their sample size being over 3,000 children. And proportion of children with ECC who developed, or ECC being early childhood caries who developed severe early childhood caries was calculated. And what was noted was there was a significant increase among 5-year-old males and children in families with income below the poverty line. And greater proportion of children with early childhood caries developed severe early childhood caries from 2017 to 2018 versus from 2013 to 2014. So the bottom line here is that early childhood caries is here to stay. So we're all going to encounter it at, various, like on a day-to-day basis in our practice. So restorations will remain a significant part of our practice. As minimally invasive as we want to be, this is just a reality, considering the scientific evidence. So I saw this patient just a few days back at the office for a recall appointment, and the mom had a million questions about the ingredients in the sealant material. So who here has nightmares like I do about these preps from dental school? Extension for prevention, a certain depth for retention, yada, yada, yada. So we've definitely come a long way, but, don't you need to get to this to achieve this? So from alloys or amalgams to composite resins, where we can be minimally invasive. So the good news is we have come a long way as far as restorative dentistry goes. So all this jargon, biomimetic versus biocompatible versus bioactive, eeny, meeny, miny, mo, it's super confusing as a clinician. So how do we differentiate between just tall claims and clinical success? It all boils down to whether a material allows us to provide minimally invasive care while being compatible to the dental tissues. And that's why I love this clarification by Berry et al. Often in the profession of dentistry, a new or novel instrument, material, technique, and/or system is introduced, which can incur a state-of-the-art status without necessarily being subjected to the rigors of clinical testing or longitudinal patient-based studies prior to receiving the stamp of approval or the moniker of standard of care. Recently, provocative terminology surrounding the field of dental materials has been publicized through the literature, promoting exciting claims and possible long-term advancements for patient care. In this new era of evidence-based restorative dentistry, conservative interdiction, that is informed removal of diseased tissue with concurrent substitution, considering form and function, aesthetics, and the interaction of the physical and mechanical properties of the replacement materials with living dynamic structures found in the human tooth, has been of paramount importance. So we're trying to mimic the properties of the tooth structure here in a restorative material. So, that is, again, a very important property to have. Biomimetics in clinical dentistry, it refers to the repair of affected dentition, mimicking, again, the characteristics of a natural tooth in terms of appearance, biomechanical, and functional competencies. So bioactivity is gaining momentum, as we can see in various podcasts and editorials and publications. The difference between biocompatible and bioactive. Biocompatibility is being in harmony with the dental tissue without causing any toxic or ill effects. And the goal of bioactivity is to promote the formation of hydroxyapatite or fluorapatite in some cases. It all boils down to evidence-based care. So based on the presented works, it seems like the emerging antibacterial and bioactive materials can be potentially beneficial in restorative dentistry. And again, good quality evidence is under clinical situations needs to be accumulated to, support those tall claims. Okay, so I don't want to go into the depth of what resin-based composites are. I mean, we all are aware of these, great materials which we use on a day in and day out basis. The properties, as we know, have limitations, but can be substantially improved and have been over the last several years. So for the history buffs amongst us, there were major developments, and they were mostly developments in three components, which is the monomers, fillers, and the initiators. So the development of our popular monomer, which is bis-GMA, is a high molecular weight difunctional monomer, dates back to 1960s. The higher molecular weight causes less polymerization shrinkage compared to acrylic resins. So increasing the concentration of the filler will lead to a reduced polymerization shrinkage simply due to the relative reduction in reactive monomer groups per unit volume. And by reducing the size of the filler particles and including multiple size distribution, filler concentrations have raised to well over 50% of the volume, which was the limit for the first resin-based composites. So just a little bit of background here. Again, this is pretty self-explanatory. Demineralization and remineralization cycle. The process of removing mineral ions from the hydroxyapatite crystals is demineralization, and restoring these mineral ions again to the hydroxyapatite is remineralization. I have included information about some of the glass resin hybrid bioactive dental restorative materials, or the resin modified glass ionomers, as we all may know them. Because they have a place in pediatric restorations. So the ones that are included here are Fuji Acquia Forte, high viscosity, and Surefill 1. While they are known for their bioactivity, they come with limitations in compressive strength, aesthetics, and longevity. But they do have a place in clinical pediatric dentistry in the high caries risk population at times for interim therapeutic restorations. So if you're interested in comparing the mechanical properties like compressive strength, flexural strength, and wear resistance for the various glass resin hybrid restorative materials, this would be a good reference to review. And here are the components of the glass resin hybrid restoratives for the chemical engineering minded amongst us. And let's review the Giomer technology here. The Giomer technology used in certain composite resins imparts great benefits like antibacterial properties, stabilizing the pH, and remineralization of dentin and enamel. These, combined with the excellent aesthetics and other desirable mechanical properties of composites, is like a match made in heaven, and we're going to see how. And here's the Shofu's line of resin-based bioactive Giomer restorative materials. I've had the experience using majority of these products and on a long-term basis, and have a lot of successful cases. Let's look at what is Giomer. So Giomer is a proprietary filler particle which is engineered by Shofu Dental. We will be going through the properties in the subsequent slides in greater detail. But the bottom line is, because of the well-studied and clinically tested and proven reasons, it is the material of choice for class 2 restorations of primary and permanent teeth in the high caries risk population, which happens to be over 90% of the patient population in a pediatric dental practice. Over here, you can see the release of 6 different ions in this graphic: sodium, strontium, fluoride, silicate, aluminum, and borate. And let's examine the bioactive and therapeutic benefits. It's not just the remineralization, it is the formation of fluorapatite and strontium apatite, which are way more resistant to recurrent caries than hydroxyapatite is. Here's a laboratory comparison of plaque formation on teeth after 24 hours of not brushing. As you can see here, Beautifil 2 composite with the Giomer filler had minimal plaque formation. And this is a great video demonstrating the acid neutralization properties of the Giomer filler particles. It doesn't have any audio, so I realized I could have inserted some mad scientist music to break the awkward silence. And here is the acid, which is fully neutralized thanks to the great properties. So this is what the healthful, or the the biofilm that occurs after in contact with the Giomer looks like. As we know, demineralization occurs below a salivary pH of 4.5, which is the critical pH. And as evident in this graphic, Giomer helps form fluorapatite, which is more resistant to breakdown. And it also helps form strontium apatite with similar remineralizing properties. So this family of material has a sound, clinically proven track record backed by scientific evidence. The key here is there is no secondary decay after 8 years, no marginal deterioration, and eventually no failures. I mean, what more can you ask for? Of course, the great aesthetics is cherry on the top. I do want to introduce you to the newest material in this Giomer restoratives category, the Beautifil Kids SA by Shofu, which happens to be a game changer in pediatric restorations. I have been fortunate enough to test it out over the last few months. It is self-etch and self-adhesive. And what that means is that the steps of etching and prime and bond are eliminated altogether for the smaller restorations like PRRs, shallower class 1s, class 5s like facials. As you can imagine, it is great when you're trying to accomplish restorations in active kids with limited attention spans. So the self-adhesive flowable composites is not a new concept. They've been around for a while. And clinicians do like the idea of faster, easier dentistry on the less cooperative patients if the products are reliable, especially for like smaller restorations like PRRs. But the existing products in this market segment did experience a high failure rate. And then retreatment of failed restorations would cost like additional overhead and affects the hard-earned reputation. So clinicians learn to be cautious in adopting this promising technology. And many who favor bioactive materials believe that bonding layers create a barrier which inhibits free ion exchange and helpful effects. So Beautiful Kids SA fulfills the promises made by other brands. And Shofu data confirms that every other product in the market segment experienced a greater percentage of debonding, while Beautiful Kids SA had no failures after 2,000 thermal cycles. And that's a lot for the life of restoration in kids. Here's another lab study published in the Biomaterials Research Report showing the excellent mechanical properties of Beautiful Kids SA. So there's a lot of good scientific evidence supporting this material and its great properties. And you will get a good overview of the clinical steps in a subsequent slide, but here's a little cheat sheet just in case. Here's a before and after on a lesion, class 1 lesion on number 31, which was treated with Beautiful Kids SA. Remember, no etch, no bond. You prep and you restore, you polish. So not bad for the results. Here's number 14 occlusal treated with Beautiful Kids SA, before and after photos. And another preventive resin restoration completed using Beautiful Kids SA on upper first and second permanent molars. Saves so much of the chair time. So while it has great properties that ensure longevity of the restoration, the elimination of etching and bonding is a huge deal for pediatric patients with limited attention span in a high volume practice. And it allows room for more same-day treatments when needed, which is quite common in when you're booking your treatments out like at least few months. Like in our practice, there was a time in summer when we were booking treatments at least 3 months out, and that's very, very long. You risk losing the patients, finding another practice who can see them sooner. Sometimes kids are in pain, so that's when you try to do these small restorations. These kids who need like 1 or 2 teeth treatment here and there on the same day, so that you can kind of make room for patients who have like more imminent and more like massive treatment needs. So here's an example of Beautiful Kids SA on tooth number I, which is the first primary molar, upper left first primary molar. Self-adhesive flowable composite was used, and this patient is 4 years old, so you can imagine how important it is to go through this treatment quickly and effectively. Here is a 6-year-old patient where the treatment was done without local anesthetic. Nitrous oxide oxygen was used. Number 19 buccal and number K buccal were restored using Beautiful Kids SA, self-adhesive flowable composite. And here is composite on I and J occlusal on a very young patient, 3-year-old. As you can see, the contacts are not even closed, great aesthetic results. And the parents mom was super happy because we were able to avoid sedation. This was done under nitrous oxide oxygen. No local anesthetic was used. Next, I will share a few short clinical videos that will help cover the technique of the restoration under isolation. This short 3-minute video is of me completing interproximal restorations on number D, E, F, upper primary incisors.
3, 4, 5, and 6.
The water.
I'll zoom in a little bit if you need to. Okay, we can pause. Oh, air water syringe, please, and a strip. Good job. And keep suctioning, please. We have a B1 shade, right?
Yes.
Okay, ready for the composite?
You want this the
Explorer.
Explorer?
Go ahead. On the facial, yeah. Okay. Like, can I get suction high speed here? Almost done, okay? Okay, we can start. It's started already. Okay, so I'm gonna start with G. Go ahead.
Here.
Then we'll add on F and Tor again. Try not to move. Very good. I'm going to polish with this. Okay, Crystal, for this you can zoom in a little bit. Open big.
Put a little water, okay?
Okay.
Little water. There.
Floss. And open big. I'm gonna floss. Open big. Perfect. You can pause.
Okay, so the patient was 4 years old, no local anesthetic was used, and the polishing that you saw in the end was with a one gloss polisher, again from Shofu. Here's a 3-year-old, and this is a 2.5-minute restoration on number SNT occlusal composite. And there are videos, photos. 2, 3, 4, 5, 6, 7, 8.
Good job.
Nine.
Sugar bugs are leaving already, okay?
And 10.
Good job,
Perfect.
Grace.
A little water.
I know it's popping out.
Okay, one more time. 1, 2, and 3.
Cool.
Let's check. Okay, nice and hard. Perfect. Let's paint it and we're done, okay?
So do you need anything?
No, just the filling. Almost done, okay?
So we're just putting the paint now, okay? Remember the paint I showed you?
The last part, okay?
That's what we're just putting on, and then you're all done, okay?
Grace, let's try to stay still like a statue now, okay? Put the brush if you can here.
So we're gonna put the little line where it's gonna make it shiny, okay?
Good job.
You're all done, Grace. You're already done, okay?
Okay, you got the focus, and I'll just a little polish video and we're done. Okay, we're gonna make it all nice and shiny now, okay?
rinse and dry. Got it.
Okay, so this is a post-op photo. So you heard my assistants kind of double checking. Hey, Dr. Nuga, no etch, no rinse, so they're like, in disbelief. So, you probably also noticed how wiggly this little 3-year-old was. So, although it only took us like a 2.5 minutes from start to finish, that's probably all we could have gotten from her, for completing this treatment. So the alternatives could have been like, just applying some STF and buying time or using some kind of sedation, but this was accomplished, in a very non-invasive manner, and avoiding sedation was great, and parents again were very, very happy, and so was the staff. This is a 12-year-old patient, and here are before and after photos and video. And we're doing number 19 PR.
Oh, that's way better. Doing really good, Misha. Open a little more if you don't mind. Thank you. Yeah. Okay, it's nice and clean. A bit of cotton roll there. And then all I need is the flowable.
No bond.
Nope.
You want to explore next or brush?
Explorer followed by the brush.
No Explorer, no Explorer. Self-Explorer. Eventually, right?
We're gonna shine our light. Polish. Let it rinse and I'll check with the Explorer. Doing really good, sweetheart. Open a little more, sweetheart. Okay, that's perfect. That is done.
Okay, so sometimes, in this video you saw sometimes you can need a cotton roll with the isolite, to just kind of keep that wing out of the way. So you have to kind of improvise. And this video will show how efficiently number 3 occlusal and C facial were restored using Beautiful Kids assay on a 6.5-year-old patient. So the good thing
Daddy, can I get the lighter shade as well?
Okay, so the good thing here is, all I wanted to point out is that, although number 3 and number C are like not their teeth that are not next to each other, it's possible to accomplish treatment very fast and effectively under isolite isolation. So it's a combination of the right isolation technique and the right dental materials that makes this very fast and efficient. Sorry, it doesn't let me fast forward the video. So I'll move on to the next slide with respect to time. So the finishing and polishing of composite resins, minimal will be needed when attention to detail is done during restoration. The burrs that I use are the 7901 football high speed, and I follow it up with the 1 gloss polisher. You probably saw me using an Explorer during, just before curing, because we want to make sure there's no voids. So the Explorer helps me eliminate any voids, make sure the restoration, the flowable composite flows into the depth of the grooves and seals it nicely. And then I like to kind of just contour it with a micro brush. Of course, when we're using a conventional flowable or conventional, packable composite, I have the bond on the brush so that it kind of doesn't, stick to the composite material. And here's a 3-year-old patient. And it's, we restored the primary incisors using strip crowns, which are, composite crowns, using the strip crown forms. Beautiful Kids SA, Beautiful Packable Composite shade B1 was used here. And this is, great results aesthetically. It's very fast. Of course, the aesthetics may not be as superior as the zirconia crowns, but with limited time, resources, and financial limitations, it's a great service to the patients. This composite crowns on the interior teeth are. And here is some strip crowns for recurrent caries and lost restorations in a 6-year-old patient. Let's look at the pre-op radiograph of tooth number C and D. This is what the clinical photo looks like. And this is after the strip crowns using beautiful packable shade B1 composite. And let's follow up on this patient who was 3.5 years old when this treatment was done. The beautiful composite strip crowns on the upper primary incisors. And the patient is now 6 years old. And again, not bad radiographically, good margins. There's no recurrent caries. So I'll take this. These teeth only need, I would say another year or so, maybe 1.5 years at the most. They'll be replaced by the erupting permanent incisors. So this is success. This is very rewarding for sure. And here's a 2.5-year follow-up on primary molar restorations and IDO, JMO, KMO, and LDO. Again, restored using beautiful packable composite. Just keep in mind that the Beautiful Kids SA is indicated for small restorations, like, shallower restorations. Because the compressive strength is different compared to your bulk fill or even your flowable composites. So again, rewards, there's a recalls can be very rewarding. Here is a 2.5-year follow-up on a teenage patient with interproximal caries on number 3, MO. And, again, restorations, MO is holding up really well. It used a beautiful packable composite A2 shade here. And at times, you can always be super minimally invasive. This is an 11-year-old with deep caries on number 19, occlusal. Not just occlusal, it's actually involving multiple surfaces, as you can see. Buccal, lingual, cusps are undermined, extends to the distal. So, we kind of cleaned the caries, had to use indirect pulp cap. And so we restored it with the beautiful packable composite A2 shade after using TheraCal liner for indirect pulp cap. And this was done under nitrous oxide oxygen angiolysis. So, sometimes this is as minimally invasive as we can get in a case like this. And this is post-op photos as well as radiographs. Not bad. Hopefully we did some service and saved the patient from getting, going through endo. So while restorative dentistry is probably here to stay in our career span, prevention remains the primary focus in dental practice in general, and even more so in kids. A large part of our practice revolves around disease prevention, caries risk assessment, nutritional counseling and anticipatory guidance at age 1 dental visits, oral hygiene and home care, and so on. Sealants, fluoride varnish, and silver diamine fluoride have solid evidence in the prevention as well as arrest of dental caries. Well, that would be a whole topic for a presentation on its own. In the meantime, sealants remain a vital part of the practice, and they're a great preventive service. They can be done by RDAs depending on the state you're practicing in, and of course, they're great practice builders because you can be fast and efficient. And here's a little video for beauty. Pretty straightforward. Okay, a presentation on restorative materials in pediatric dentistry or in clinical pediatric dentistry would remain incomplete if we did not include stainless steel crowns, because these are like the gold standard, or should I say steel standard, in a pediatric practice. They have excellent track record, and they have great level of scientific evidence in various RCTs and meta-analysis. They have high long-term clinical success rate. They're very less technique sensitive, unlike the zirconia crowns. So it's very, very easy to place. They're moisture tolerant and forgiving, when you have a wiggly child again. And of course, there's the Hall crown technique where you which does not require prepping of the tooth at all. And if you have a child who would not sit through a quick stainless steel crown prep, or even local anesthetic for that matter. Okay, so this little kid only had just would not sit through a conventional restorative dental appointment. So we had to improvise, and Hall technique is great. It's highly evidence-based, and the crowns stay for usually as long as the life of a tooth. So because the oxygen supply of the bacteria in the caries lesion is cut off, and sealed off from the environment, which is the saliva. This is a stainless steel crown on tooth number I, and there's a reason I have this particular case here. This is pre-op. This is what the tooth looked like, pretty bombed out from caries, as you can see. And here's post-op. So all of you who place stainless steel crowns on kids on a routine basis would know that, although this is the first primary molar, we had to use a second primary molar crown. We had to use an E on this particular tooth because even the biggest crown size, which is like D7, would not fit after like a lot of prepping on this tooth. So, you know, again, you have to improvise sometimes. There's no cookie cutter approach when it comes to pediatric dental practice. You have to, you know, keep kind of sometimes reinventing the wheel and, you know, being creative around these kids. And that's what makes it a lot of fun. So here is the final restoration. And I did want to show this slide on the Hall crown because, you know, again, you know, you're wondering how will it stay and how long will it last? But here is a 2-year follow-up on a Hall crown in a patient. And this was done on tooth number T. And as you can see, great occlusion. The kids, you know, the occlusion adjusts like right away. It's amazing how, you know, how forgiving these stainless steel crowns are. Not bad on the radiograph. I mean, yes, you see that little like tiny overhang on the distal, but hey, you know what? This is SSC, and I mean, it's going to serve the kid this tooth the purpose why it was placed. So behind every picture, there's a story, and the story behind this picture is very special to my heart. This 10-year-old girl, Yeva, a refugee from Ukraine, had to move to Poland first and eventually moved with her family to California. And she was referred to us by the general dentist, where she was really scared and could not get through the treatment appointment. And because of her Medicaid coverage, it was really difficult for them to find a pediatric dentist. And we do take Medicaid. So she did great with us, and the joy of being able to help this family exceeds any monetary reward in this world. It just reinforces our vision to help the kids who need us the most, regardless of their insurance status. So I'm very grateful for moments like this. And, you know, this is the treatment that we did for her. And again, I was able to do same-day treatment on her, and the uncle and the mom were beyond grateful. You know, the mom did not, uncle was this translator, mom didn't speak any English and understood very little. The girl barely spoke any English. So we did number 3 OL, number A MOL, number T MO, and number 30 occlusal using beautiful products, you know, with the Giomer technology, and you know, with nitrous oxide oxygen. The patient did really well. And so she just needs to come back for the left side now.
I'm gonna put this little pillow to help you stay.
And this is just a short.
Higher. And remember the rules. Very easy. As long as you keep looking at the TV on the top and keep breathing through your nose, we're gonna be done really fast. Okay? I'm gonna put a few drops of the cold sleepy juice in your gums. Shake. Take a nice big breath in and out. Perfect. Can you do that one more time? Wow, I can see your tummy going up and down. Up and down. I love how you're breathing through your nose and staying still like a statue. That is perfect. Great job. So next, sweetheart, we're gonna put a raincoat so that you don't swallow any yucky sugar bugs, you don't taste anything. And then this pillow is gonna help you stay open, okay? The raincoat stays in place with the ring. It's just like a finger ring. Give me a finger. There you go. So it's gonna give your tooth a little hug, just like you hug your little brother, okay? So you tell me if it's not tight. I can always make it a little tighter. Okay, perfect. That's my ring. Is it nice and tight there? Yeah, perfect. I can see you're enjoying the little movie you're watching. And this is my raincoat. You'll hear a lot of stretching, okay? Stretchy stretch. And this is what's going to keep everything nice and dry so you don't swallow any water, any sugar bugs when I'm brushing your tooth, okay? Perfect. We're ready to rock and roll. Your head up, honey. And I'm going to start brushing your teeth with a special toothbrush, okay? If anything ever bothers you, gently raise that hand and I'll stop, okay? Perfect. Great.
Okay, so I just had this short clip from this particular video because I wanted to help shed some light on the patient management aspect here, the behavior management aspect, which is so important in kids, because the last thing we want is for them to get traumatized because they didn't have a good experience, and then you're losing them, and they'll be nervous and scared even to come back for like a recall or prophy visit. This patient was only 5 years old in this video, and she successfully got through the local anesthetic and rubber dam placement and the whole quadrant dentistry, including the prep and the restoration. So again, no one size fit all approach when it comes to treating kids, whether it is in like behavior management or isolation or material selection or, just treatment planning and management of the disease in general. So but then that's what keeps it fun and for us as practitioners and for the entire team. And here's my 2 kids, my 17-year-old who just started college this fall, and my 13-year-old son, he is an 8th grader. So I am happy to answer any questions, any comments that you guys may have, and this is my email. Thank you so much, everyone, for this opportunity, and good luck in your practices. Take care. Bye.